It's a privilege and honor to introduce Barry Schaitkin, who's going to speak to us on facial paralysis, diagnosis, and electrical testing. He's from the University of Pittsburgh and has had an interest in facial nerve his whole career and has contributed significantly to this. So we appreciate your time. Thanks for joining us, Barry.
Thank you very much. Honored to be invited. I changed my title a little bit past electrical testing. I thought I'd talk a little bit first about diagnosis. One of my favorite parts of the Academy meeting when it exists in person is the facial nerve study group. And the facial nerve study group for generally at this point starts off the meeting early in the morning, and people from all over the world present difficult cases. So, you know, in my day, you could see, you know, Dr. House or Dr. Brackman, Ugo Fish, Mark May would, you know, come to the facial nerve study group with interesting cases. And it was, it continues to live on and be a really dynamic place to have discussion. And I think because a lot of facial nerve problems present to otologists, it's nice to have some of these things that I'm going to talk about in your armamentarium. And then we'll get into electrical testing. And the two talks dovetail together quite beautifully. So in seeing a new patient with a facial paralysis, history is everything. You know, I think that almost, you know, it lends itself to the current video telemedicine kind of visit, because a detailed history will get you pretty far, as you'll see from the things we'll talk about. Most of the patients who come to see me have been labeled as Bell's palsy, no matter what they have. Even when they know what they have, they get called Bell's palsy. And so they read about now on the internet things about Bell's palsy, and they're, you know, woefully ill-informed about their disease process. So Mark May used to say that Bell's palsy present like peas in a pod, and anything that isn't presenting like that is a lima bean and a pea pod. So if you don't have this kind of history that's listed here, you know, that should beg the question of what might you have. And I know we're in an era where everybody gets every test, but you know, this is going to get you pretty far in terms of who should you work up and how should you work them up, as you'll see as the talk goes on. But basically, Bell's palsy generally starts with some kind of preceding symptoms that before the face goes out. 60% of them have pain with it, which is a common thing for people come to see me being told that nobody gets pain, so they must have something else. So these kinds of things, you know, I think are useful to know. Lots of different things come in as Bell's palsy. Some of these are the more serious ones that I've seen over the years, being told they had Bell's palsy, and we'll talk about them. The first thing you want to get out of the history is the progressiveness of the problem. So, you know, Bell's palsy should be sudden, not slowly progressive. It generally is maximum in the first 3 days, although, you know, people will give you a little grace there, maybe a week or two, but, you know, Bell's palsy happens very, very quickly as a rule. Anything that doesn't do that, or that starts with twitching that then becomes weakness, should be thought of as being a neoplasm. It's also important to know that although sudden onset complete paralysis is common with Bell's, we also have tumors that will present with a sudden onset complete paralysis. 10% of patients who have a Bell's palsy will have a second episode, and 2/3 of those are on the opposite side of the face. So this often gets people excited for other diagnoses too, but it really is not that uncommon. You know, 1 out of 10. I saw one yesterday, so it's something you should think about. Ipsilateral recurrence, on the other hand, I always work up more extensively for neoplasm. You should have in your background some list of what causes a bilateral facial paralysis. And by simultaneous, I would say within a month of the first side going out, the second side goes out. In Pittsburgh, from April to November, Lyme disease is the most common cause of a bilateral facial paralysis. I know that's not true for everybody watching this talk, but the rest of the year, Bell's palsy is still our #1 bilateral. But I did, just have a leukemic last month, sarcoidosis, a variety of things that you have to think about. And these kind of things, will present to you as clinical conundrums. In a child, Bell's palsy and Lyme disease are still very high, but there are some other things you have to think about. There are a number of textbooks, including the one by Slattery, our own, that will give you a nice set of tables on bilaterals and things to think about in different subpopulations. Fortunately, most of the tumors that we see in children are benign, but they require you have to image the right place to make the right diagnosis. So these are the things I really want to put into your consciousness, okay? So first one that we talked about is twitching or hyperkinesis that precedes paralysis. That should always be worked up for a neoplasm. So, this was a lady who had seen a couple of ENT doctors for dizziness. She had normal head and neck exam. She couldn't get through her EEMG due to emesis. She had told me that, since then she was still having some double vision. It's been like that for 6 months. And when I looked at her, she had some very fine twitching of the lower eyelid. And I don't think these are going to play. That's okay. Very fine twitching of the chin and the lower eyelid that made me suspicious that something else was going on here. And she ended up having a brainstem lymphoma. Paralysis that doesn't resolve in 6 months. This one, is probably the most common thing that we see, somebody being told that they had Bell's palsy and then it doesn't get better. Here's a gentleman who came in to see me. He basically went to the ER, had his ear irrigated, woke up the next day with a facial paralysis. He was told he had Bell's palsy. 6 months, he wasn't any better. Somebody at 6 months got an MR that you see there's enhancement on the left side at the IAC GG area. And, he was told this was consistent with a Bell's palsy. So he had no improvement at a year. And actually at a year, the enhancement was a little bit less. He came to see me for eye reanimation, but I told him that, people really a year with no improvement, even with modern imaging, there's times when I still explore these patients. And when we explored him, he had a tiny lymph node that was sent for frozen. But the most interesting thing he had was a thickened great auricular nerve in the parotid. And when I sent that, that was a perineural invasion of squamous cell carcinoma. So he had squamous cell carcinoma in the lymph node and the nerve. He got eye reanimation and then chemo RT for an unknown primary, probably a skin cancer. The great auricular, he had a neck dissection, but he basically died of perineural spread back to his spinal cord through the great auricular perineural invasion. Similar kind of thing that, this is a patient, 77 years old from overseas that found me on the internet. She had paralysis for over a year. She wanted to come for reanimation. Her history was that, she had been admitted to her home country, had a big workup, saw a bunch of specialists, and they basically told her that, it was Bell's palsy and sometimes it doesn't get better. So, that's a red flag for me. So when I took further history over the phone, her lower face actually went out, her upper face went out before her lower face. And the thing to know about this, for the otology community, is that the facial nerve is not organized into branches until it reaches the parotid. So anytime you get a history that something happens of one part of the face before another part of the face, you should be thinking parotid. And the problem with all of this imaging is that it was all done of the CNS. So it never looked at the parotid, or it certainly didn't look at the parotid in detail. So, when I hear upper face, lower face, not at the same time, I'm thinking high resolution imaging of the parotid. That showed a poorly defined parotid tumor. And I would point out another thing, and that is that the harder it is to find a parotid tumor on imaging, the more likely it's malignant. So CT scan, in fact, I had one of these this week. CT scan, didn't see a tumor. Ultrasound, they were kind of vague on whether there was something abnormal to needle, but on MRI, they could see a tumor. So the harder it is to find these on imaging, the more likely you're going to find malignancy. And she had some immediate, this is post-op day 1, after just some immediate reconstruction after her parotid neck dissection for salivary duct carcinoma. Slowly progressive paralysis. This should also, get you excited as far as it's not Bell's palsy, it's not Lyme disease, it's not herpes zoster. Think about some other things. So here's a lady with a 17-year history of a slowly progressive facial paralysis. She had been told over the years that she had Bell's palsy. This was her ear exam, which, is very telling. You can see the corresponding abnormality in the mastoid with erosion from the facial canal to the EAC. And, you could see her tumor in her ear canal. So no surprise there, but I mean, slowly progressive schwannoma. Schwannomas, as you know, generally don't present as facial paralysis if they're in the parotid, and they present pretty late if they're in the intracranial space. It's only when they're intratemporal that they are compressed and you get schwannoma presenting as facial paralysis fairly early. All right, isolated branch paralysis. So as we've gone down the list, you kind of get a sense of who is at risk here. So this was a young lady who, when she was taking pictures of herself in Disney World, noticed that her lower lip on the right side just didn't seem to move as far down as the left side. It's subtle, but it's real. She had told doctors for 4 years that she had a lymph node or a lump in her neck parotid region. Everyone said it was just a lymph node, young, healthy person, leave it alone. Anyhow, CAT scan was normal, MRI was normal, FNA was normal. That's ultrasound guided. I did an open biopsy, which on frozen they called dysplasia, but the final was mucoepidermoid carcinoma with perineural invasion. So she got the whole deal, and a good result with a nerve graft. 74-year-old man came in to see me. This is the kind of case that you hear about at the facial nerve study group. A week after a dental procedure, he developed numbness, and then he didn't have weakness, but his PCP told him that he had Bell's palsy, put him on prednisone and acyclovir for this facial discomfort and numbness. Then he developed, a month or so later, he developed weakness. He went to see a neurologist who did Lyme titers, treated him for a month with IV antibiotics. He got worse on antibiotics. The neurologist said, well, Lyme disease is like that sometimes. He saw a different infectious disease specialist, and they basically said, it's not Lyme disease. They sent him to ENT. The ENT doctor feels a parotid mass, tells him, the patient said, I told everybody I had a parotid mass. So the ENT sends him for a CT guided needle aspirate, but there's no mass on CT. So the patient's told by radiology there's no mass to biopsy, and the ENT tells him there is no mass, even though he had felt a mass. Nothing more to do. He calls me on the phone. You can guess what I told him. And he also had a salivary duct carcinoma. Similar case of a pediatrician who I just saw. He's 20 years out from this story. He had what was called a Bell's palsy for a upper face weakness. He got near complete recovery with steroids, but 4 months later, he was vacationing in California. He was at a pediatric conference. He was told he should have a middle faucet decompression for recurrent bells. He got less recovery the second time. He went back home to New Jersey, had a transmastoid decompression, which even at the time we weren't doing anymore. He had eye reanimation by Dr. Levine, who many of you know. He contacts me by email and gives me the story, and I tell him he has a parotid cancer. So he looks like this at the time. I think it's great. He sent me a picture with Nelson's Pediatrics. His eye is a little ptotic from the eye spring. He has a complete facial by the time he calls me. So I told him he should have an MRI. I'm worried he has a parotid cancer. He told me his parotid was cleared on MRI prior to the spring placement, but he sent it and it really wasn't high resolution of the parotid. So I tell him to get a new MRI, but you know, a lot of places won't do MRIs on somebody who has a palpebral spring. So that's something to, you know, just think about. We have a protocol. Levine has a protocol for eye spring and MRI. Anyhow, he eventually gets an MRI here in Pittsburgh, and you can see there's a deep lobe lesion that, you know, is fairly subtle, but again, you know, these are the things to worry about. Recurrent ipsilateral paralysis should be on your list. This lady came to see me with a third time recurrent facial paralysis. You can see at the level of the IAC and the GG, she's got what looks like a mass lesion. Something people don't talk about that we're going to talk about on the electrical testing, and that is that people like this, most of us focus on the amplitude of the ENOG, but people with an increased conduction latency, you should be thinking neoplasm. And we'll talk about that a little bit more. A little more obvious tumor on the MR, which turned out to be a schwannoma. She elected for leaving it in place. It was decompressed. And we did at the time, it was a while ago, I did a 12/7 jump graft with a terrific result. So, you know, that's going to be what I want to get across for the diagnostic part, you know, when to think something other than Bell's palsy with focused imaging of the area of interest. Now we're going to talk a little bit about electrical testing. And the electrical tests that we use for facial paralysis, you know, it's primarily EEMG and ENOG. So all of this testing, you have to think about, you know, what's unique about electrical testing for facial nerve problems. Most of it is that we're doing very downfield testing. We can rarely test across the lesion. So we're looking at CNS, temporal bone, facial nerve pathology, but we're studying the nerve from the stylomastoid foramen out. So that's, you know, something that the orthopedic doctor, if they have like an injury to the upper extremity, they can study something right across the area of injury. All right, so you know, some of this does require you to think a little bit about what happens during a nerve injury. So I think it's good to remember that, you know, the closer the injury is to the cell body, the more traumatic it is. And the process that occurs after the injury in terms of, you know, what's going to be happening, both in terms of these electrical tests, but also when you start thinking about reanimation surgery. All right, so EMG. So when you do an EMG, you're basically putting a needle into a muscle and you're sampling just what's at the tip of the needle, okay? So it's a small sample of muscle fibers at the needle tip. And with that, you get three basic pieces of information. So when you put the needle in, that's called the insertion response. Then you study the muscle, what happens when the patient's face is at rest or any muscle is at rest, and then what happens when they try and move the muscle in question. So this is where EMG comes in. So what can it tell me? So with insertion activity, the normal response to sticking the needle into the muscle is a short discharge burst that the muscle basically says, ouch. If there's been denervation, you get what are called positive sharp waves. So on the top A here is the typical ouch of just putting the needle in and normal insertional activity. And on the bottom, B, is the sharp wave activity that suggests denervation. So this is the first piece of data that you get when you start doing the EMG. Insertional activity will be, decreased if you have muscle atrophy or fibrosis, but most of the time when we're doing this, it's before those things occur. All right, what about a muscle at rest? Well, as you can imagine, a muscle at rest should be fairly quiet. So once you put the needle in and you're past the insertion stage, and you ask the patient to relax with needles in their face, it should be fairly quiet. Anything that isn't quiet is fibrillation activity. So, after you get past the insertion activity, you're looking at this kind of thing. This is the pattern that we're seeing in this particular patient when the muscle's at rest. And these are called fibrillations, and fibrillations, as you know, are bad. It's the strongest evidence we have that axonal degeneration has occurred. So when does this occur? It usually occurs about 2 to 4 weeks after injury. So although there are times you're going to want to get an EMG acutely, and we'll talk about that, most of the time, if you're sending your patients to neurology for EMG or neurophys for EMG, they're going to want you to wait 2 to 4 weeks because they're going to want to look for fibrillation activity. So you have to tell somebody what you're looking for if you're trying to do an EMG before 2 to 4 weeks. So the next thing is muscle contraction. So voluntary motor unit action potentials that occur when you ask the patient to move their face. Now, obviously, if they can visibly move their face, this test doesn't add much to your thinking about what's going on. So what you're looking for is electrical evidence of recovery before you see clinical evidence of recovery. So an EMG generally is not very useful if there is movement. So when you get asked on your boards, about a facial paralysis that either is incomplete or delayed, in general, these are not people who need surgical exploration. So, getting an EMG at that point is not the right answer. An intact nerve should have what's called recruitment, as demonstrated here. And that is that the more effort the person puts into moving the face, the stronger the activity should get, as we see from left to right. When somebody moves their face, in general, you should see a biphasic or triphasic response in the EMG. Anything more than triphasic is called polyphasic. Polyphasic is characteristic of nerve recovery, nerve regeneration. So when you see polyphasics, it's due to nerve sprouting to denervated muscle fibers in the neighboring units. And polyphasics are indication that the nerve is getting better. So we don't like to see fibrillations, but if we see fibrillations, we do like to see polyphasic activity because we know that we're getting recovery. So this is sort of a normal, triphasic kind of response. I'm sorry, this is a, didn't even look at it. This is a polyphasic response, more than 3 phases, and this is a sign of regeneration. Okay, so that's EMG. The next test that is really important to otolaryngologists is the ENOG. What Mark May and I, call EEMG because it's really measuring a muscle response, not a nerve response. But really, the whole world calls it ENOG, and so no matter what you see on my slides, you should probably call it ENOG, or nobody will know what you're talking about. So this test is done by a supramaximal stimulation of the facial nerve in the face, and then measuring a response. And the original papers are well known to everybody from fish. So what is done is the normal side is tested first, and then on the paralyzed side, again, you don't do this on somebody who has an incomplete facial problem, but on the paralyzed side, you either do one of two things, and you just want to be consistent, meaning that every time you test people that you do it the same way, so that within your testing site you have consistency. So either people will pick a standard placement where they put a surface EMG recording device along the nasolabial fold, or they will stimulate and they will move the recording device along the face until they get the maximum response. Having done hundreds of them here, we do a standard placement, and I know that the people who do it, are comfortable doing it. You want to make sure that, you're sending somebody who does have expertise, because it is a test that requires consistency. And then what, as I talked about, what you get from this are two things. So the thing that we mostly talk about is the amplitude. So, the peak to trough measurement of the response on the paralyzed side, and we compare that to the normal side. But don't forget about the latency. And the latency is how long does it take to get from when the stimulus is applied to the onset of the response. And as I said, in our experience, patients with neoplasms generally have an increased latency, and in our testing site, that's generally something more than 3.5 milliseconds. So when I see that, it's a diagnostic part of the ENOG. In other words, most of the time when we do an ENOG, we're doing it for prognostic information. It's somebody who has a paralysis, most commonly viral, but also Lyme disease, also trauma. Okay, but we're basically looking for a prognosis on how the nerve is going to recover. And this, this measurement has been most studied within the first 10 days of onset. So if somebody comes to see you at a month and you do this test, we don't really have great long-term data on what people's testing looked like at a month. In other words, you're looking at a shape of a curve from 100% from the bad side to the good side to 25%, 10%, et cetera. And those tests that lead to perhaps a middle fossa decompression being considered are based on early measurement. And it wouldn't be a bad idea for a bunch of us to get together to do some testing on late comers and see if we could find anything that's useful prognostically. This is the woman I showed you with the 17-year history. Here she is like at Christmas. Not clear why it wasn't getting attention, but you see the increased conduction latency. She still has some amplitude, but it's the conduction latency that should really get your attention. All right, so that's sort of how the two tests work. So when do I use these tests? Okay, so first off, as I said, they're used prognostically for Bell's palsy. So for Bell's palsy or zoster, during the first 10 days, once they're complete, I will get my first test as soon as I see them. And this is only helpful if you see people early. So, the ERs in my neck of the woods know that I will see these people, the next day I'm in the office after the onset for a visit and electrical testing. So, because if you don't see them for 2-3 weeks, if you're not set up to see them early, the electrical test, as we said, loses its importance. Certainly, the big studies that looked at prognosis, like Pedersen out of Europe, thousands of patients, they they're talking about the first 10 days. All right. So when I'm talking to people about their prognosis for Bell's palsy, if they're incomplete, that's the best possible Bell's palsy result. In other words, people who 40% of patients who get a Bell's palsy will not go all the way to complete paralysis. And if they don't need electrical testing. And in our series, they have a 98% likelihood of a House-Brackman 1-2. The next group is that they drop to 25%. So if you drop to 25% of the normal side, you still have a 95%. So if you're 25% or better, you still have a 95% House-Brackman 1-2 recovery. And not only do you give them some information about how good the recovery is likely to be, but you can also tell them they're going to recover early. So people who have greater than 25% generally start to recover, not complete the recovery, but they initiate their recovery in the first 3 weeks. The next group is arbitrarily 10 to 25. And in this group, the likelihood of that normal or near normal recovery drops down to about 70% in our testing center. So if they're down, 11 to 25, that's a 70%. They're going to take a little longer to recover, 3 to 6 weeks, kind of recovery. And then the worst group, the group that all the papers are written about pretty much, and the reason that everybody talks about Bell's palsy and what to do is the less than 10% group. And as all of you, as being neurotologists, know, this is the group that may be considered for decompression for a Bell's palsy, based on the Gantz study, the Fish study, etc. Last time I surveyed the ANS about who was doing middle fossa decompression for Bell's, although everybody thought that it was what you should do, and it was what they put on their board exams, most people hadn't done one for 10 years. And given that these people are around, it would suggest that very few people are actually doing it, even though they think it's helpful. They had a variety of reasons, including, most commonly that they don't see the patients early on in their evolution. Okay, so it's used prognostically. What about trauma? So we talked about incomplete delayed, they don't need anything. But if you get a complete paralysis, let's say, you're doing a mastoidectomy and the patient wakes up with a complete facial paralysis, and you obviously were not expecting it. And you've done all the usual things and locals worn off and all the rest of it. But now you're looking at a patient with a sudden complete facial paralysis. And as far as you were concerned, the nerve was intact at the end of the procedure. So if you called me, the first thing I would ask you is, were you using nerve monitoring, and did you stimulate at the most possible proximal site that you could have hurt the nerve at the end of the procedure? And if you did, and if you got, a low stimulation confirmation, that's very reassuring. What if you didn't? Or what if it's not a mastoidectomy? What if it's a temporal bone injury? Then, I'm going to recommend that you get a EMG on that day, or as soon as they'll do it for you. And what we're looking for on the EMG, and this is the case we talked about, where you have to talk to your testing site, because most ENTs don't do EMG in the office. To talk to the testing site and say, all I want to know is, are there voluntary motor unit action potential? The presence acutely of voluntary motor unit action potentials, of course, means that the nerve is intact. Now, the absence doesn't mean the nerve is not intact. It could just be significantly traumatized, but the presence is what you're looking for. Don't forget, like in a temporal bone trauma, the things that you're looking for are, is nerve continuity interrupted? And if so, how, how do I know that I should go in and do something? And so what you're looking for in that case is a sudden complete paralysis with CT imaging that suggests a fracture of the fallopian canal in the area of the facial nerve, and supportive electrical testing. So in the presence of those three things, you can feel pretty comfortable. All right. So you call them, you tell them you're looking for voluntary motor unit action potential. If the nerve is transected, okay, you will not have voluntary motor unit action potential. Because of Wallerian degeneration taking 3 days, you will still have an ENOG response for the first 3 days, but then it should very, very quickly go away. So, testing earlier than 3 days with ENOG might give you a false sense of security. Yeah, and so for ENOG, we'd recommend waiting 3 days and then test it 3 days. And if there's still a response, maybe again at 6 days. Sometimes we've seen patients who have some facial movement and somebody got an ENOG and they have no ENOG response. And here are the couple of the things that will give that kind of response that you're thinking is, how could that be? The first one is that if they've had a previous Bell's palsy or other kind of facial paralysis, and now they have a second episode, because ENOG requires synchronous firing, remember that we said, we're stimulating on the face over the main trunk. We're stimulating over the main trunk, and then we're getting a synchronous response of a maximal stimulation and looking for recording. So if they lack synchronous firing, they won't have a good response. So that's something to keep in mind. Tumors, particularly benign tumors, but I've also seen this with adenoid cystic carcinoma. Tumors can cause a nerve injury that has simultaneous denervation and recovery. So very slowly, the nerve is being infiltrated with a tumor. You might see fibrillations and polyphasics on an EMG, which your neurologist is going to say the nerve is recovering, but it may not be so. And the history is going to be really, really important in those cases. Finally, newborns may lack the neural maturity to give you synchronous firing. So, if you have a unilateral facial paralysis in a newborn, we're going to talk a little bit more about that next, but if they say, they got no response, the question really is, well, what about the normal side? Because if they got a very poor response on the normal side, but no response on the abnormal side, you don't really know what that means because it's probably related to the neural maturity of a newborn facial nerve. Okay, so voluntary motor unit action potentials as an acute application, that's very, very valuable and something that I don't think is used as much as it could be. Look for these kind of things for a combination of ENOG with a prolonged latency and or EMG with simultaneous evidence of denervation and recovery as a sign of tumor that your electrical test is giving you that isn't just about prognosis, because I think we're kind of locked into thinking about them prognostically. So, what kind of cases might this be useful? So this is a lady who came to see me. As you can see, she can only raise her right eyebrow. So she has a left frontal paralysis and the rest of the face is fine. And it turns out that she had recently gone to see a vascular surgeon who did bilateral normal temporal artery biopsies, and the post-op, the left frontal branch didn't come back. And you can kind of see why that happened, because on the left side, this incision was in a different location than it was on the right side, and you have this resultant paralysis. So this is a case where electrical testing will give you some idea of how's the nerve going to do, so you can tell her prognostically. Diagnosis is not the issue of course. What can you tell her prognostically? And this is a case where EMG can be very helpful. A young man, he was ice climbing near Pittsburgh. He fell, he was in coma. He had obviously a very, very serious injury, pelvic fracture. He awoke with a facial paralysis. And this is going to happen to you not infrequently. So, people who we have no idea what their early time course was for their facial, for a variety of reasons. Maybe they're obtunded, maybe they're in coma, maybe they're so sick that people didn't think to look at their face at the beginning because they thought they were gonna not make it. So this patient comes to see me at 4 months, young man, he's got a full facial paralysis. What do you do, right? So it's not a case for ENOG. We don't really know what ENOG would mean at this point. It's a good case for EMG, okay? You wanna know, given that there's no evidence of facial movement, what does the face look like on EMG? And, the CAT scan, the hearing, it goes without saying, you're going to do all that. Complex temporal bone fracture. In our series, and this is a paper, an early paper that Mark and I did together that never got published, but in our series, temporal bone fractures with no evidence of electrical recovery by 4 months almost never recover. So it's not really out there because it never really made it because of problems with the data set, but I do still use that as a rough indicator of trying, because what are you trying to do? You're trying to intervene in a patient with a facial paralysis before it's too late to do a facial nerve graft or even a nerve substitution. So you want to intervene before the nerve is no longer capable of receiving that kind of reanimation procedure, but you don't want to do that procedure at all if the nerve is going to recover on its own. Remember, at the end of the day, the best result for all facial nerve problems, if possible, is still to get the facial nerve nucleus hooked back up to the face by whatever means. All right, so he had positive motor unit action potentials at 4 months. They were even greater at 6 months. I don't think my Zoom is going to participate, but he had a great recovery when he came to see me at 6 months and went on to have a really good recovery. And at 4 months, he had nothing. So, I think it's really important. Similar kind of person with a motor vehicle accident, multiple injuries to the temporal bone, dead ear, no function, but at 3 months, she developed motor unit action potentials, and you can see a tremendous recovery in the picture. Where you can be of help is to our obstetrician colleagues when a facial paralysis presents at birth. When it presents at birth, they always want to assume that it was the obstetrician, that it's always traumatic. And, the reality is, of course, some of these are congenital. So you have to be thinking, so what could I do to know whether it's traumatic or congenital? So by definition, a congenital paralysis will not change over time. And a traumatic paralysis assumes that you had a normal face, and it's just like the cases I just presented, right? That over time, if there's any evidence of recovery, even bad recovery, synkinesis, hyperkinesis, twitching, tone develops, anything that develops over time was traumatic. Anything that stays the same was congenital. So, this is a table from a paper that we did and put in the OB literature, but this is what you're looking for. A developmental paralysis will have no evidence of recovery after birth. They generally have no other anomalies, no other cranial nerve problems. Their temporal bone will be normal except perhaps MRI of the facial and the fallopian canal. On electrical tests, if you do an ENOG, it should not change from day one going forward. And an EMG, because you have to know that congenital facial paralysis will often have some facial function. Sometimes lower division, sometimes upper division. They're not always complete, but whatever they have will not change over time. So an EMG that results in fibs, fibrillation potentials at 2 to 3 weeks, that was trauma. Okay, an ENOG that decreases in amplitude over time, that's trauma. Obviously, temporal bone fracture. You don't see a lot of fractures in newborns because their skull is almost more like cartilage than bone. It's more like a smush kind of injury than what you just saw on some of those CT scans. But this is really, really important in the first week, 10 days of a newborn's history, and then going forward in trying to sort out developmental from traumatic facial paralysis.
Hello, my name is Dr. Kevin Peng, neurotologist here at the House Institute. Thank you for watching this video. The House Institute provides free educational videos for hearing health professionals worldwide. To help support videos like these and other educational efforts, please consider donating by clicking the link in the description box below. Your generous support allows us to keep videos like these at no cost for you and others. Thank you.